Okay, so let's start session one. Session one is distal or Hilar stricture cases. Okay, so I'd like to introduce our first speaker. First speaker is Dr. Kazuyuki Matsumoto from Okayama University. Dr. Matsumoto, can you hear me? Can you hear me?
Yes, I can.
Okay, he's one of the he's one of my junior. He worked in with us maybe 10 years ago. I forgot, but
Yeah, maybe. So,
yes, yes. Uh, he is a
thank you,
very
Dr.
very
Kataruma.
great
Yeah.
rising star in Japan. So, Dr. Matsumoto, could you please start your lecture?
Okay. Okay, let's start. Thank you, Chairperson. Today, I'd like to talk about management of malignant Hilar structure and technical tips for multi-stenting. So when we perform drainage for Hilar biliary structure, we should consider these two issues. First, should we do unilateral or bilateral drainage? Second, should we use plastic stents or metallic stent? Lee from Korean group published a report comparing unilateral or bilateral drainage for inoperable high-grade malignant Hilar biliary structures. According to the report, the median stent patency was longer in bilateral drainage than that in unilateral drainage. Clinical success was also better in bilateral drainage than that in unilateral drainage. Regarding using plastic stents or metallic stents, Mukai from Japan reported about the efficacy of metallic stents for malignant Hilar biliary structures. In their report, the stent patency of metallic stent was significantly longer than the plastic stents. Moreover, the total treatment cost, including re-intervention for stent obstruction, was cheaper when the metallic stent was used. Thus, basically, we recommended bilateral drainage with metallic stent for malignant Hilar biliary structures. Then, which drainage method is more suitable for bilateral drainage? As you know, there are mainly two methods of multi-stenting for Hilar malignant structure, namely stent-in stent and side-by-side. Recently, hybrid method, which is combined these two methods, has also been reported. Up to date, there have been some reports about the drainage methods for management of Hilar structure. However, the best approach is still controversial. This slide shows the advantage and disadvantage of SIS and SBS method. The advantage of SIS method is multiple metallic stent placement in one stent caliber, which means it is physiologically ideal. And the disadvantage is through the mesh technique is technically difficult. On the other hand, the advantage of SBS method is that it is technically simple at initial placement, but the disadvantage is overexpansion of the CBD due to parallel stent, metallic stent placement. We have an experience of a case with pseudoaneurysm after SBS method. 4 weeks after stent deployment, the patient had blood tissue with shock vitals. We performed coil embolization for pseudoaneurysm at the right hepatic artery. The suggested cause of the pseudoaneurysm was overexpansion of the CBD and mechanical simulation of the RHA by the metric stents. In our institution, we have performed multi-stenting with SIS method for Hilar structure. Dr. Kawamoto and Kato first reported the endoscopic SIS method for Hilar malignant structure. Now, I will talk about the technical tips for multi-stenting with SIS method. First, we divide the liver into three parts: the left lobe, the anterior right segment, and the posterior right segment. We don't need to perform drainage in the segment where the portal vein is obstructed. Second, we select the less bent branch for stenting. This is because that there is a risk of stent kinking when we place the stent at a highly bent branch. Thus, B2 is better than B3, and B6 is better than B7. Third, the initial stent should be placed at the first branch of the bile duct. If we place the initial stent as in the left image, the placement of second stent will be more difficult because the stent insertion route is bent. On the other hand, if we place the initial stent as in the right image, the stent insertion route is straight, and we can pass the second stent through the mesh more easily. Fourth, we place the initial stent at the highly angular branch. If we place the initial stent as in the right image, the mesh of the stent is more open compared to that in the left image. As a result, second stent can easily pass through the mesh. Thus, the order of deployment of metallic stent is from left bile duct, posterior bile duct, and then anterior bile duct. If we choose a different order, the procedure will become very difficult. Next, I'm going to talk about the tips for through the mesh technique. Through the mesh technique with guide wires and the stent delivery system is sometimes difficult. We often use the seeking and reading guide wire. And the seeking guide wire needs to have an angled tip and good manipulability. NaviPro by Boston and Large Focus by Telmo are adequate seeking guide wires. The reading guide wire is the guide wire for reading the delivery of the metallic stent to the target branch. Stiffness is necessary for a reading guide wire. When we using the reading guide wire, the axis of the stent insertion can be kept stable. Also, we can use the pulling tension of the guide wire. Jag wire by Boston and THSF by Cook are adequate reading guide wire. The landmark guide wire is the guide wire which acts as a marker of the bifurcation of the bile duct. As this guide wire is only show location, any 2.5-inch guide wire is suitable. The landmark guide wire makes the through the mesh technique easier to do by showing the route to the target branch. I will show a video for SIS method in the next slide. First, the initial stent is placed in the left bile duct. So these are landmark guide wire. Next, we seek the B6 using a seeking guide wire with reference the landmark guide wire and follow the catheter and then change it to the reading guide wire. After that, we insert the second stent in the posterior branch. And now deploying. So finally, the third stent is deployed in the anterior branch. So guide wire and catheter can go straight through the mesh. We can then insert and deliver the third stent easily. If we follow the proper order of stent deployment and understand the properties of guide wires, we can perform multi-stenting more easily. We can also manage the stent obstruction after SIS method. We usually use both seeking and leading guide wire and the tapered tip plastic stent. To use these devices, we can place the plastic stent into each metric stent and manage the stent obstruction. This slide shows that efficacy of 3-branch drainage with metric stent for patients with inoperable hilar biliary carcinoma in our institution. Among the patients who achieved disease control with chemotherapy, both stent patency and survival of patients with 3-branch drainage are significantly higher than that in patients with only 1 or 2-branch drainage. Therefore, adequate drainage may allow continuous chemotherapy and prolong the prognosis. So this is a summary. Successful placements of multiple metric stent can be achieved when we understand the theory and the properties of devices. Adequate drainage allows continuous chemotherapy and prolong the survival in patients with inoperable hilar biliary cancer. Thank you very much.
Okay, thank you very much, Dr. Matsumoto. Here you show us, how to manage malignant hilar biliary strictures. Okay, so it's time for open for discussion. Are there any questions or comments from panelists? Or if you want to ask some question to Dr. Matsumoto, please use Q&A system. Okay, so Dr. Matsumoto, you love the stenting stent method. Your institute is very famous for stenting stent in Japan. But now, what kind of technique do you use? Do you usually use?
Now,
You still yes, you still perform a stent method or a stent
yeah,
side by side method.
thank you very much. We are familiar with SIS methods, so we usually use SIS method. But so recently, so we have some experience of hybrid method for multi-stenting.
Mm-hmm.
Yeah.
You mean hybrid is transpapillary and US guided or something like
A
that?
transpapillary hybrid method,
Okay.
side by side and combinates. So side by side and
Okay. Okay.
yes, yeah.
Okay. Thank you. Okay. Question from Dr. Ogura.
Okay, thank you for the good lecture. So my question is reintervention. After multi-stent deployment, reintervention may be challenging. So recently from Chinese group, plastic stent deployment with radio frequency ablation using Habib devices may have clinical benefits such as prolonged overall survival. So we recently performed multi-stenting using plastic stent with RFA. How do you think this strategy?
I think maybe it's good for prevent the re-obstruction of stent, but so I have no experience of using the Habibu RFA device. So I want to try. Thank you.
Thank
Dr.
you.
Ogura, do you have any
Oh.
experience of RFA? Have you?
Yeah. Recently, we tried to clinical trial.
Mm-hmm. And what was the result?
Now ongoing.
Okay, thank you
So
very much.
I will notice you in the future.
Okay, so next, Dr. Shomi.
Well, thank you for excellent presentation. Your presentation is easy to understand how to management the biliary obstruction. I have two questions. And first, I think it is difficult to pass a guide wire through the mesh of the stent when intervention is needed after partial stent in stent. And how is the technical and clinical success rate of intervention after partial stent in stent? Next, do you use metal stent or plastic stent during a reintervention?
Thank you, Dr. Shiomi. So first question, the technical success rate of reintervention after SIS method is about 80 to 85%. And all of the patients with technical success achieved clinical success. But technical success is defined as successful stent insertion into each metric stent. So namely 3 plastic stents for 3 metric stents. So 2 plastic stents for 3 metric stent is defined as technical failure. Thus, some patients with technical failure showed it improved clinical symptoms without further endoscopic procedure. So in total, about 90% of patients could achieve clinical success at first reintervention.
Okay, so finally, I'd like to ask Professor John. In Korea, what is the most popular drainage method? Stent is still familiar, or other side by side, or plastic stent method?
In Korea, I don't exactly know the situation, but in my experience, I prefer the side by side stenting, because it's a technical difficulties low.
Okay, thank you very much.